Good evening. I bring regards from Mayor Vitabiotics. Greetings to
Yes.
all who have joined this program. As you all know, that fathers are considered to be the pillar of strength for any family. And on the occasion of Father's Day, Mayor Vitabiotics, who is leader in global fertility
I put it
nutrition
on silent
and
actually.
Put it on silent.
fertility
Okay. No, I
adjuvants,
put it on
is
silent.
very
Okay.
glad to
Should we start?
present this wonderful podcast with
Sir,
two
we're
great
ready.
Are
personalities
we
today
ready?
that we have on screen.
Wait, he's saying wait.
Yes,
So,
yes, go ahead.
So today we have, hello.
Yes, yes, go ahead, sir.
So today we have Dr. Tejas Gundewar from Pune, India, who is a fertility consultant and andrologist in Jeevan Ram and Ruby Hall Clinic, Pune, honorary consultant at AIMS Nagpur. Dr. Tejas Gundewar is first MCH in reproductive medicine and surgery from Maharashtra, holding a gold medal. Recipient of MRCOG from London, he had his andrology from the University of Miami and have been reviewer of JHRS, that is the Journal of ESAR, Human Fertility Journal, Fertility and Sterility, and had lot of publications, national as well as international, to his credit. His obviously the field of interest is fertility and andrology, and today he will be interviewing and questioning one of the global experts in andrology, Dr. Ranjit Ramaswamy. So I hand over this session to Dr. Tejas Gundewar to introduce the speaker and as well as take the session forward. Thank you.
then start. Start.
Hello and welcome to a very special Father's Day episode. Fatherhood in today's day and age is evolving, but it still reflects strength, resilience, unwavering support, and unconditional love. I'm Dr. Tejas Gundar, fertility consultant and andrologist from Pune. And today we are going to discuss sperm and beyond. And whom better to discuss with? Someone who can find a sperm when there is none. Someone who can make a not so good looking sperm look so good. Someone who can open those blocked tubes and get you natural pregnancies. Guys, ladies and gentlemen, reintroducing Dr. Ranjit Ramsamy, Uroandrologist, Dubai, UAE. He is someone whom I've always looked up to, not just for his unmatched expertise in men's health and andrology, but for his depth of character and mentorship beyond the clinic. Welcome, Dr. Ranjit. It's truly special to have you here.
No, thank you. Thank you, Tejas, for doing this. And obviously, thanks to Meyer and thanks for Vitabiotics for sponsoring this Father's Day podcast. And very happy to discuss sperm and beyond. We'll see what lies in the future, what we know so far, and what we don't know, and what we are going to learn, hopefully, in the next few years.
True. And as Ranjit sir said, who better to have as academic partners than Mayor Organics, somebody who has been at the forefront and giving parenthood to a lot of infertile male couples with a lot of different drug formulations, oligocare 4 being one of them. So Ranjit sir, let me start with this, a very, very basic question. There's a lot of buzz regarding this. Is male infertility on the rise?
There have been studies that are published on global sperm counts declining compared to the 1950s to the 1990s. And then now in the 2000s, sperm count seems to be lower than it was. There are some discrepancies in the studies that were done back in the day compared to how we count sperm now. But I think we are in practice. We see patients. I'm sure we all recognize that the prevalence of azoospermia, prevalence of oligospermia is definitely going up. In fact, you are an IVF ART specialist, Tejas. You do know that the most common reason for ART, most common reason for couples undergoing IVF ICSI these days now is actually male factor infertility. Few years ago, 10 years ago, studies done in the 1990s where female factor infertility was the most common cause. But I think low sperm count, no sperm count at all, I think is probably the most common reason why couples are undergoing IVF. So I think it is a real phenomenon. We as practicing clinicians see it on a day-to-day basis. I think on a population level, we are seeing trends. We don't know for sure if that is what is happening, but I'm fairly certain in a few years, it is going to become more apparent.
Okay. So, Ranjit, see, what I feel is if you look at the WHO manuals and if you look at these concentrations, say, for example, concentration or the total sperm numbers, how much have they changed? Initially in the 1990s, 2000s, 2010, maybe they said that 20 million was normal. Now they're saying that 16 million, more than 16 million is normal. So total sperm numbers or concentration, total sperm numbers, how much they have changed? Initially, they said that 40 million, the total sperm number, more than 40 million should be normal. And now they're saying that more than 39 million should be normal, is normal, right? Does that actually translate into decline in the objective criteria? Okay. So my take means what I feel on this is from the Indian perspective, what I feel is we get today marriages are happening late. We have females delaying parenthood beyond after getting married. Subtle male factors which were prevalent before also are just coming across now because a young female, a young oocyte has a higher capacity to fertilize a sperm to overcome abnormalities as compared to a older oocyte. This is what I feel. And objectively, I feel whatever we've seen the WHO criterias, objectively, if you see in terms of the concentrations per motility, things have not changed too much.
Right. No, I think you bring up a very good point of is this a global decline that we are seeing? And yes, you're correct. Compared to WHO 2010 to 2021, we actually don't see much of a difference in the 5% cutoff that is used as normal. So I agree over the last 10 years, I don't think it's changed much. I think we're talking about the last 50 years. Has that declined? And what's going to happen, not in the next 10 years, not in the next 25 years, but what's going to happen during this century? Are we going to see decline in sperm counts happen over the next century? We don't know the answer to that, but I'm happy that we actually have a standardized manual with WHO where we are now objectively looking at sperm counts and sperm parameters across all the 5 continents, as opposed to only 3 continents that were selected in 2010. In 2020, I think all 5 continents have been included. So I think it's a more reliable and robust data. But we'll see what happens in 2030. We'll have a better sense of what's happening. But one point that you brought up was delaying parenthood, both on the female side, both on the male side. Right. And I think we see a lot of premature ovarian failure, eggs counts going up as women get older. Sperm counts can go up. I know we don't ever talk about male reproductive aging. As men get older, you can have children anytime men want as they get older. But the quality of sperm can go down. Smoking, environmental factors, just aging, quality of sperm count can decline. Correct. So the chance of fathering a child naturally at an older age is definitely lower than the chance of fathering a child at a younger age. Absolutely. And yes, as long as you marry a younger female partner and she has very good egg reserve and good egg quality, they are going to fix the defects in the sperm.
That is always a chance.
But when you have an older female marrying an older male, you're going to struggle with fertility. Correct. So I think male reproductive aging is a phenomenon that exists. How it exists, what happens to sperm quality, what happens to mutations with time inside the sperm, I think we don't know entirely.
Absolutely, absolutely. I think epigenetic changes, this is a lot of things. There are a lot of complicated things when you in India. And they've shown that the fertility rates have declined to 1.9, which means that we are, as of now, India is not going to replace its population. So now the point is that the total fertility rates have declined, So one reason is either fertility itself is declining, or people are trying to have voluntary infertility. I come across so many couples who say that I would like to freeze my embryos. We don't want parenthood right now. People
Right.
would say that we want to have only one kid. That's it.
Right.
So total fertility rates, maybe that is the reason why total fertility rates are declining. Nevertheless, let's consider this aspect that fertility is declining as a whole. And then in that case, we would require more clinicians. So I want to ask you this, Ranjit sir, that going back to your urology days, what made you decide that you want to subspecialize in andrology?
So was to try and have a good quality of life. This is very selfish, right? I wanted to do surgery. I wanted to be in the operating room. But at the same time, I said, I want to do elective surgeries and have a good quality of life. And so one of the specialties, subspecialties within urology, I thought andrology did this very well. In addition to having the gratifying feeling of helping male partners and couples, very good specialty to go into, because I just didn't like the adrenaline rush that some of the surgeons require within urology. Andrology as a subspecialty definitely offered this. So this was a big motivation.
Nice. So, but how was the scenario in the US back then? It's been more than a decade.
Yeah.
Almost 2
Yeah.
decades. You decided that you wanted to do andrology.
Right.
Is that correct?
Yeah, that's correct. That's correct. So
how was the scenario? Did you have trained andrologists then,
Right.
or it was very naive?
No, it's a very good point. There were when I applied for andrology fellowships, andrology was not a very sought after subspecialty. Within urology, the cream or the best went into oncology, robotics, laparoscopy, endourology, female urology. And then people who really didn't do well in urology chose andrology as a subspecialty because it was not a sought after specialty. We had very good mentors. At Cornell, we had Peter Schlegel, Mark Goldstein. At Baylor, Larry Lipschultz and Dory Lamb. I mean, we had very good pioneers in the field who were moving the field forward. But I think as a subspecialty, it was not a very sought after specialty. But now I think things have changed. People recognize that fertility rates are declining, prevalence of male fertility is increasing, prevalence of male sexual dysfunction is increasing, given rising rates of obesity, smoking, hypertension, metabolic syndrome. And so I think andrology is becoming a bit more of a sought after specialty compared to robotics, laparoscopy, and oncology.
Nice, correct. So you've been running these andrology fellowship programs for years together now, and what do you think are actual roadblocks when you want to train young urologists or young general surgeons, or whoever? Means like me being a gynecologist, I was with you for some time. So what do you think are the actual roadblocks when it comes to training andrology? Andrology training?
No, excellent point. I think andrology resides within the urology subspecialty, but we do know you're an IVF ART specialist. You know it takes two to tango. It's a couple's issue. It's never a male decision versus a female partner decision.
Absolutely.
You have to include female factors into what we do in the male factor decision. And I think there are very, very few fellowships. Actually, I don't know of too many that have a coexistent
combined approach.
And I think training in silo, treating only the male partner, treating only to improve male outcomes without full knowledge of what happens with the female, full knowledge of what happens in the IVF cycle, what happened in the previous IVF cycle, what are the embryo outcomes. Without knowing all of that, to train urologists in silos within urology departments, I think is very difficult. So I think it'll be nice in the future for people that are thinking about developing programs to set this within the auspices of an IVF center, to set this up in the auspices where there is a combined fellowship, where urology trainees and IVF ART fellows learn both the male and the female together so they can understand how to tackle problems better.
Absolutely. I think a super point made that where we are supposed to, whenever we are talking about fertility, I think male and female factor fertility potential should be considered together when you are deciding on the management for that couple. So I'm sure that this is the way forward where even if urologists who want to train in andrology, I think they should understand what's the ovarian reserve, what is the fertility potential of the female, so that better decision making is done.
Correct.
Better decision making is done, and I always feel that it should be a one-stop fertility solution where one person is taking care of all the things
Right.
for fertility as a couple.
Right. No, I agree.
So let me tell you, sir, you've been an excellent mentor. What did you make? So we come across people in our life where we are sure that this is the person that I would like to be, and then there are people in your life where you decide that, oh yes, this is not somebody I want to be. Honestly, Ranjit sir has been one person where I felt that I want to be something like him. Uh, he's been an excellent mentor, and I really want to understand from him. And there are things that I've learned from him from the mentorship point of view, where a simple example where if you're going to publish a paper, making somebody else's name as your first author and you becoming a second author or a third author, I think that's a simple example what mentorship means. And I've learned this from Ranjit sir, and I really want to know from him that did you have a good
Happened all the time.
This is
Yeah.
your
No,
this is
no.
your thing.
No, absolutely. I think I had
This is RR thing.
yeah, no. So I think I had very good mentors who set the standard. I think we mentioned both, Peter Schlegel, Mark Goldstein, Philip Lee at Cornell, and then Larry Lipschutz, Story Lamb at Baylor. Very good mentors who set the stage and a foundation for this is what good mentorship looks like. And I think just like how we come across people, mentors are like that. There are good mentors, there are bad mentors. There are some good behavioral habits that you pick up from some mentors, and then some other people that you're like, oh, that's not what I want to do. And I think as long in life as we embrace all of the good habits and then keep it with us and foster it and grow it, and then try to ignore all of the bad habits and try not to become like one of those bad habits, I think we'll just get better in life. I think that's probably what it led to as a culmination of all of those things.
Nice. So when you are giving your UISR oration today, I just saw your first paper of 2005, where you are the first author and Peter Schlegel is the last author. So I think that's where I got the correlation.
Correct.
That
Right.
yes.
No, absolutely.
So that was the inspiration for you. I'm glad that I've been introduced to you through SRMC.
Nice.
So the next point is you've been a part of Indian conferences for so long. It's almost been a decade. You've been a part of, on and off, you've been part of Indian conferences. What do you think about the young Indian talent pool or work ethics? You've been interacting with a lot of young Indians. All of us from SRMC come to you. We used to come to University of Miami as a part of our MCH training program, and now the trend is followed when you are in Dubai. So, what do you think about the young Indian pool? What do you think we are going ahead? Where are we going ahead? And do you find any difference when it comes to the Indian talent pool or young Indians and the young Americans? And you can decide not to answer the question. That's okay.
No. So I'll tell you this. I think there is a huge need for andrology training. We spoke about prevalences in male fertility going up. We spoke about prevalence of azoospermia going up. We spoke about the need for good microsurgery, good understanding of male fertility in basically the entire world. And so I think Indian trainees, they're very passionate. They understand that their time exposure is very limited. And so therefore they try to absorb a lot of knowledge within a limited amount of time. They don't take anything for granted. And I think that drive of, oh my gosh, this is my one opportunity to learn. Let me do the best I possibly can and learn the most I possibly can. Because when I go back, I need to take care of all of these patients and all of these issues that present to me and do a very good job at what I am doing. And I think I've seen both trainees from urologists from India who have come over, all of the fellows from Ramchandra that have come over, like yourself. And I think that is one uniform theme because there are not too many formal training fellowships within India. I think the need to learn from outside of India exists. And I truly admire the passion that all of the Indian trainees come with. So I'm very happy that this collaboration is continuing in Dubai.
And we're so glad that you understand that we are passionate about this field and we want to make a difference to the field of andrology with experts like Dr. Ranjit Ramasamy. So, brought up in the US, I guess you are in the US for quite a long time. And then whenever you come back to India, I love the fact that you visit your family in Chennai and you speak excellent Tamil. Oh, I mean, obviously, initial part of your life you are
Yes.
in India, so that's fine. So, what keeps you rooted? What keeps you rooted here? What makes you keep coming back here?
So one of my first trips to India was in 2012. This is when I first met Dr. Rupin Shah. This was in Nadiad. And he had invited me, I think when I was a resident, to come and teach at his andrology course in Nadiad at MPOH. And as a resident, I was truly honored to come and deliver faculty lectures
Lecture.
along with Rupin. And it was, I mean, now Dr. Vineet is doing this, but Rupin's been doing this for over 20 years in Nadiad, I think, at MPOH. And to come to an audience of about 100 trainees who were there from 8 a.m. till 6:30, 7 p.m., the lectures were still going. They were still taking notes. They, for 2 or 3 days in a row, I had given about 6 or 7 lectures as a resident. And the amount of knowledge that was consumed, the amount of passion that I saw, truly motivated me. I said, this is such a huge, satisfaction that I wanted to come back and sort of give back to the community where I figured that there was this big need and a gap in knowledge in andrology that existed. So I think that's probably what drove, and obviously I've continued my associations with Dr. Rupin. I mean, legend in urology, knows just about every question in andrology that I can ask him, and he will always have an answer. And I think it's fantastic that I can come back and contribute back. And I think that's probably what drove the interest in wanting to come back and trace back to the roots, to give back to the trainees over here.
Nice. Absolutely. So true. But whenever I've had a discussion with you regarding cricket, I never thought that you were too passionate about India as a country. And I was way too passionate about India as a country. But then that's okay. I think.
No, cricket, I mean, you always grow up, playing cricket, watching cricket. America never had a cricket team. So it's very easy to continue to follow India. And of course, Chennai Super Kings did horrible this time, but we still root for them.
Nice. So, my next question is, what excites you the most? Sorry, wrong question. I mean, in clinical practice, what excites you the most?
No, it's so I think the practice
microsurgery, microsurgical TESI, microsurgery, VVVE, or giving natural conception to patients by medical therapy. What gets you the best? What excites you the most?
So I think the one thing that excites me the most is I feel it's not the surgery. I've done too many surgeries, but it is the outcome. The feeling that I was able to intervene in that couple's journey to provide a chance of biological parenthood. And had it not, bragging a little bit, had I not been there, maybe it wouldn't have happened. But I'm very happy to have contributed to that small piece that means a world to that couple.
Oh, absolutely.
Right? Finding that 10 sperm, that one sperm becoming an embryo, no embryos, 3 IVF cycles before I did a simple TISA varicocele repair. Now they are able to have embryos and father a biological child. I think that small intervention there, for us, it looks small because it is only
For
one
them,
patient.
it's too big.
Yes,
It's too much for them.
Yeah, for us, it is just a very small intervention because it is
Absolutely.
one among 40 patients that we saw that day, one case among the 4 cases that we did that day. But for them, it went from 0% to 100% to carry a child.
Absolutely.
And it changes their life completely. I think that's what still motivates me. It is not that patient that we were able to help that excites me the most, but it's the other patients that we were not able to help. Why didn't we get more sperm? Why couldn't we form embryos? Could we have used cells that are a little bit more immature to have made embryos? Why did that embryo not implant despite being euploid? I mean, all of those questions, I think it's what still continues for research and trying to keep pushing the field forward.
Nice. So I'm sure. I think for us also giving because we've learned from you, obviously giving parenthood to couples with self gametes, I think that gets maximum pleasure from
Right.
whatever you want to do. So that's obviously the highest when you talk about it. So now we've spoken about clinical practice, how you've grown in a uroandrology field. I always the thought always keeps bragging me that you've had more than, for all people who don't know, he's had more than 500 publications. So I'm sure so many clinicians within one state of India may not have that much publications. So one person can have so much publications. I really want to understand what's the motivation that keeps you going to do so much of research, to publish so much. What makes you do this?
So 2 factors. I think questions that still remain unanswered. I always want to go back and either refer to my own publication or to go back and put the message out there in terms of publications. So anything that I'm doing new, that I'm innovating, that we have done differently for the last X number of cases, that we think that the outcomes are good and its success is good, I think always motivates me to let's go write this up. Let's go back and look at this. This is an unexplored area within male fertility or andrology. Let's go back and look at this cohort to see what happened with these patients. I think that drives me. The other big driver and motivator that you mentioned a little bit earlier is young trainees who want to see their name published, who want to figure out how they can move forward in their career, and can publications help in their own career. And I think trying to support them and trying to support young people in their own careers, I think is a fantastic idea. So both the combination. One, to try and see if we can answer unanswered questions, and to try and support young people's careers, I think is the combination for why I publish so many and continue to publish.
Super. So I think there's a stark contrast when I look at clinicians in India and clinicians in the US, where publishing is pretty common thing in the US as compared to India. We come across so many clinicians who do excellent work, and you've already spoken about Rupin sir, and Rupin sir has been a legend in the field of andrology, and I'm sure you admire his work, and all of us admire what he has done. So basically, what I feel is clinicians in India don't publish that much. They do excellent work, but they, for XYZ reason, I think multiple reasons. One is research should be as a part of your curriculum when you grow up.
Right.
I think it should be part. And now, with so many medical colleges in India, medical students probably have some time for research. Back in the past, where the clinical load was so much that beyond the clinical load, research was just not possible. It was just not possible. So I think that is one of the issues why we as clinicians in India do not publish as much as you do in the US, despite doing probably good work,
Right.
but we are not able to put up in the way that it should be put up. And as I said, that you're not groomed to do that.
Right.
And I think the grooming has to start somewhere.
Right.
Grooming has to start somewhere Indians as clinicians, in terms of means you may call it as a prejudice, but I think Indians have enough talent and enough good clinical work to tell what they are doing.
Right. No, absolutely. I
So-
think I cannot agree more. Yes, majority of the publications and research comes from US and now from China, right? I think the number of publications and impact factors
much.
in China has probably exceeded the US. But that doesn't automatically correlate to most of the clinicians are publishing in the US, right? Just because most of the publications are coming from a select few clinicians and researchers in the US and China doesn't necessarily mean majority of the clinicians are doing research, right? So that's not true, because most of the clinicians are very happy doing clinical work. That's what we all went to medical school for, to become doctors, to become good surgeons, to become good physicians. Why is this scenario, right? I think the biggest driver is money, right? So if there is research funding, either from the department in academic institutions, either from central philanthropy institutions, from non-profit organizations, or in the case of China, the national government is funding so much of the research right now. I think anytime there is finances associated with research and publications and funding, I think you're going to see research output go up. We live in an age of economics, right? We absolutely are driven by economics. We work for hospitals, corporate entities. IVF clinics are being bought out by private equity, VCs, and so money is the bottom line. And somehow, if we can have money allocated for research, you will see research output in India go up. You're absolutely right. Clinical work in India is excellent. Volume, number of patients, number of cycles that get done in India are tremendous. Yes, not as much as China, but definitely tremendous high volume. But hopefully in the future, large IVF centers that have now established in India will allocate some percentage of funding and money for research, hire dedicated research assistants, hire dedicated PhDs who are trained to analyze large volumes of data, and sit down with the clinicians and try in collaboration. I don't think as clinicians we can sit down, we can be like, oh, let me answer this research question, go and do it on your own. I don't think it happens. Team science, it has to happen with a statistician, data analyst, and all of this money needs to come from either private organizations or from government entities. I think when you see that change happen, you will see research output go up.
Correct. And I think, as discussed, I think you need to have a very dedicated time for research.
Right.
So when I was in the US, I remember, I guess it was Wednesday, when there used to be only research work. There was a big hall where you used to do, everybody used to present what they are doing. And there was only research work that was discussed on those days, no clinical work that was done.
Correct.
If I'm not wrong.
Yeah, no, absolutely. It has to be funded, right? Funded. That day has to be funded.
And funded, intention, and giving it correct time, that enough output will come out of it.
Correct. Or meaningful output.
Meaningful output. Right. Or what we, at this moment of time, probably majority of clinicians in India do not think that research is going to take them to places.
See, it's not, and people ask me this all the time, does research translate to money? That is the question. Oh, you published all these papers. Is that paying you off, No. It's a very simplistic notion, but somehow research publications get tied to reputation. Reputation ties to ChatGPT, Google reviews, right? So somewhere it does translate.
It does.
And patients these days are very savvy, very well educated. They know PubMed as well as we know PubMed. ChatGPT knows PubMed as well as we know PubMed. And so they Google who is the best azoospermia doctor in the world. ChatGPT is looking at PubMed publications. It is not looking at which private equity bought which IVF clinic, how many IVF centers in India. It's not looking at how many IVF cycles were done in XYZ IVF center in India. It's looking at research academic productivity. And so it does translate to revenue. So when people always ask me, oh, you're publishing all these papers, or is this translating? It does translate.
It does. I think not directly, but indirectly.
And the other very important point is, especially after having moved to Dubai, I can tell you, we need research publications to come out of our areas. Middle Eastern region, Indian region, South Asian region. We take all of the outcomes from the Western world and we just apply it blindly to be like, this RCT done in the state of Kentucky showed this drug was better than this drug. Let's use it now in Pune, India, because we're going to have the same outcomes. It is not. Patient population is different, response is different. We are in an era of personalized medicine. So trying to translate outcomes from China and the US and trying to apply it to the Indian, Middle Eastern population is not going to work.
True.
We need to generate our own data. We need to have support, funding, dedicated people who will help this effort. Clinicians cannot. You want to make money? I want to make money, right? This is very obvious. So we need to make the effort to try to see if entities, corporate entities, private entities, government entities will support this
be a part of this. Absolutely. So I think we've had a lot of discussion regarding how do you grow as an andrologist, uroandrologist, or a reproductive medicine specialist. Let's move gears and let's now move to the myths and facts regarding male fertility or sexual dysfunction. I'm going to ask Ranjit sir a few myths and facts, and this is going to be useful for, I guess, a lot of clinicians, and it would be useful for family physicians as well to understand that what are the myths regarding this. So, Ranjit sir, there are a few questions I'm going to ask. You can tell me whether it's a myth or a fact, and then your explanation for that. All right. So, frequent ejaculation causes male infertility. Myth or fact?
It's a myth. In fact, frequent ejaculation has been shown to decrease the risk of prostate cancer. So definitely a myth. It is not associated with sperm counts at all.
So I recently had one patient where the patient said that the patient had night wetting. Okay. He doesn't masturbate. He had night wetting, spontaneous ejaculation is there. And he kept on saying that I feel extremely weak after ejaculation and I can't grow muscles because I'm ejaculating. So, what do you tell the patient?
So nocturnal emissions are a completely physiologic phenomenon. So nocturnal emissions will not cause decrease in muscle strength, will not cause fatigue, decrease libido, or decrease in energy. It's a physiologic phenomenon. It happens all the time to most people. And so nothing to worry. So again, nocturnal emissions causing weakness the next day is a myth.
Masturbation causes infertility. Biggest myth.
Does not cause infertility. Again, another physiologic process. I always tell people it is a tube, it's a fluid, it needs to get flushed out. And so therefore, whichever process it gets flushed out, it cannot be associated with infertility.
So do you come across, we come across a lot of patients where they say that after having sex, all the seminal fluid comes out, and then that's the cause of infertility. Can you give, and there are clinicians who would say that, oh, we are going to give you some medicines so that the fluid doesn't come out. How do you counsel them?
So this is during vaginal intercourse. You're saying that the fluid comes out. So as long as there is no incompetence on the in the vagina, as assessed by a gynecologist yourself, I think a little bit of fluid leaking out is completely reasonable. I think it's a complete myth that you have to be in this position after you have sex for the sperm and the seminal fluid to reach the egg in the fallopian tube. I think all of that is myths. If you have enough sperm, it will enter the vagina, it will enter the cervical canal. A little bit of fluid leaking out is completely reasonable and normal.
So my way of telling the patient is, whenever the semen ejaculates, there are two parts of it. One is good sperms and one is bad sperm and the semen and the liquid fluid. The bad sperms and liquid fluid is going to come out. The good sperms are going to go in. So that's what I just tell them, just to make them understand that that's okay. If sperm fluid leaks out, that's okay.
Right.
Masturbation shrinks the penis size.
Again, absolutely not. If any erection, the penis is a smooth muscle, and erection basically increases the smooth muscle. In fact, quite the opposite. People who have erectile dysfunction, who have prolonged many years of ED and are unable to get an erection, that may shrink the penis, that may decrease the erectile length, but masturbation, having an erection, definitely will not decrease penile length.
Two more things regarding sexual dysfunction. One is erectile dysfunction and premature ejaculation. erectile dysfunction, men with erectile dysfunction are considered as infertile.
So, also not true. Just because you have erectile dysfunction and you are unable to obtain an erection does not mean your sperm count will be low. Or they just actually quite the opposite is what happens. Men with very good erections, with very good libido, with very good orgasms think that they have normal sperm counts. That's also not true. All of erection, orgasm, climax, seminal fluid, ejaculation is all tied to testosterone. As long as men have normal testosterone levels, they will have all of those functions working just fine. But we do know that 30% of men with azoospermia will have low testosterone. So that means 70% of men with azoospermia will have normal testosterone. So just because you have good erections, good orgasm, good climax, doesn't necessarily mean your sperm count is okay. But I've had men tell me this all the time. Why is my sperm count 0? Why is my sperm count so low?
When my sexual function is absolutely normal.
Correct.
Absolutely
yes,
normal.
So both are not true. They're yes, the penis and the testis are very close to each other, but they receive very different blood flow. They work completely different mechanisms. And just because you have one normal doesn't necessarily mean the other one is also going to be normal.
So I think I always keep telling the patients that there are two different functions. One is the fertility function and one is the sexual function. Fertility function depends on your sperms. The sexual function is your erection and ejaculation and all that.
Right.
So I think that's where we need to differentiate, saying that fertility depends upon, because it's a common understanding that whenever, obviously, means if it's a sexual function, because people think that sex is meant for reproduction.
Right.
So sexual function, sexual happiness, and fertility, these are not considered differently. And same with premature ejaculation. So many times we have patients, the patients will tell me that, sir, I ejaculate early. And is that causing infertility?
It's not. I mean, in some cases, you don't need to, the female does not need to achieve an orgasm for fertility to happen. And so as long as the ejaculation happened and it happened in the correct place, anatomically, I think the chances of fertility are still there. However, premature ejaculation is a very frustrating condition. A lot of men suffer in silence with premature ejaculation. Partners are frustrated. Patients are frustrated. Unfortunately, unlike erectile dysfunction, treatment for premature ejaculation is actually pretty ineffective. And so therefore, I think appropriate treatment, counseling, both medications and psychotherapy are all very important for men with premature ejaculation.
So I think it is very important for us to emphasize the fact that premature ejaculation relates to sexual function and not fertility.
Correct.
For fertility, what is important is a male partner ejaculating into the vagina, and that's it.
Right.
Right. So,
and I think you do know this very well. Any of the ejaculatory dysfunction, situational anejaculation, premature ejaculation, delayed ejaculation, all of that can be simply, as long as the sperm count is normal, treated with IUI. And I think patients need to understand that. And sometimes getting over the stress of fertility, oh, my wife is pregnant now, may actually solve some of the ejaculatory issues because there is one less stress in your life now. And so I usually, anytime there is ejaculatory issues and the sperm count is normal, which we know it can be, most likely it will be normal because both are not tied together, IUI is a very good treatment option for that.
In fact, I used to visit this place called as Baramati, which is close to Pune, where I had a patient who told me that the patient faces only situational anejaculation. Whenever they want to try during those important fertile period, that's where he's not able to ejaculate.
Right.
So instead of, as you said, that why not do an IUI? So I told him that why don't you do an intravaginal insemination?
Right.
I taught him how to do an intravaginal insemination.
Right.
Take it in a jar. Take a syringe. Just put it inside the vagina. Masturbate. Put it inside the vagina.
Right.
Few months later, I got a call that the wife is pregnant.
Yeah.
So I think they did not even do IUI.
Right.
I think intravaginal insemination, in case if the semen parameters are good,
right,
I think intravaginal insemination is a very good option.
Absolutely.
It's a very good option because anyways you want to deposit the semen inside the vagina.
Right.
One more thing I keep coming across is sir, the semen has become very liquidy. And
Watery.
yeah, watery.
Yeah.
And then I take antioxidants, I take oligocare food, and then, oh yes, the semen has become thick.
and viscous.
And then
Yes.
they think that it means better fertility.
Right.
So that is another myth that comes across where
No, I think people need to understand that. So PSA is prostate specific antigen. It's a common blood test that is used for screening for prostate cancer. But basically, PSA is what liquefies the semen. And it is not necessarily produced in the same amounts all the time, every time. And so sometimes when it is high, it liquefies the semen very well. If it is low, it does not liquefy the semen very well. And so, but there is absolutely no connection between watery consistency of the semen and sperm parameters or fertility outcomes.
Correct. So now let's dwell on the last part. Let's dwell, and then we're going to take some questions. Let's dwell on this part of how do you boost fertility naturally for male partners, right? So apart from exercise, dietary habits, anything that you want to tell, antioxidants, what would you like to tell the male partners that how do they boost their fertility naturally?
Got it. So this is Father's Day. We're trying to see if we can improve chances of parenthood and fatherhood. And more importantly, I think the question that you're asking is biological fatherhood, right?
Absolutely.
So what are things that we can do naturally to try and improve your sperm counts? I think anything that is good for your overall health is also good for your sperm. So so if you're going to lose weight to try to improve your health, it's going to improve your sperm counts. If you're going to increase exercise and both cardiovascular and muscle training exercise to try and improve your overall health, it's also going to improve your sperm. If you're going to cut back on smoking or stop smoking altogether and cut back on alcohol, sleep better, to improve your overall health, that's also going to improve your sperm. So I think in general, people shouldn't think about, oh my gosh, can I do something specifically to improve my fertility? I think if they go back and say, I'm going to take care of my overall health better, I'm going to eat better, sleep better, exercise more, and I'm going to improve my overall health, I think your sperm counts are also going to improve naturally.
Nice. I think perfect. That's all what we can summarize when we want to boost fertility naturally. I think let's take a few questions.
Sure.
We have a few questions, and then we can call it off. So, male partner having good sperm count, but motility is 4%. What do you want to do next?
So that's a very good question. So normal sperm concentration, meaning the testis is making a lot of sperm, and then as the sperm leaves the testis, it is getting killed. Right. That's basically what is happening in this situation. You look for organic causes of obstruction. So either ejaculatory duct obstruction or any sort of inflammation that's happening in the epididymis with epididymitis, orchitis, prostatitis, any sort of infection, inflammation that's killing the sperm. As long as if it's there, then you should go ahead and treat it, either surgically or medically. But the one place where I think antioxidants will actually help very well is in try to improve quality of sperm. Guys making a lot of sperm and the sperm motility is low, morphology is low, and the quality is not good. I think in order to achieve a good redox balance, antioxidants can help a lot in that situation.
Nice. So, so the next question is, how do you treat oligoasthenozoospermia other than clomiphene citrate and tamoxifen?
So there is medical therapy to try and improve OATS, but the most common cause of oligospermia in men is actually varicocele. These are dilated veins around the testis that can increase the temperature of the testis. And if the female factor is normal, as evaluated by the gynecologist, and they are young and they want to conceive naturally, I think if you have a clinical varicocele and oligospermia and normal female factor, you should think about correcting the varicocele.
Nice. So, so the question is, what do you do with isolated teratozoospermia? I think we had a good discussion regarding this
morning, yep.
in the morning, but then I think we can tell it to the viewers again that what do we do with isolated teratozoospermia?
Got it. So if the sperm morphology alone is abnormal, but the sperm concentration is normal and the sperm motility and the volume are normal, then considering both natural conception and insemination is completely reasonable. Even when the morphology is 0%, chance of IUI success and natural conception success is similar to men who have normal sperm morphology. I think that is a very important take-home message. Where morphology becomes very important is when both the sperm concentration and the motility are low, or all of the morphology is uniform, wherein 100% of the sperm have no heads at all, 100% of the sperm have no acrosome, 100% of the sperm have pinheads. That's when there's some underlying genetic defect which requires more advanced reproductive technologies to try and help solve that puzzle. But most of the time, abnormal sperm morphology is not to worry about. Patients always ask me the question, oh, it says my sperm has double heads. Is my kid going to have two heads? It doesn't make sense that that's what will happen. Just because you have a bad looking sperm doesn't necessarily mean it can't father a good pregnancy.
Absolutely, absolutely. I think this is a very, I also keep getting references from gynecologists saying that morphology is bad. But in the presence of a good sperm count and motility, I think morphology can take a backseat, and decisions regarding fertility can be taken based only on the sperm count and motility, where we call as the total motile sperm count.
Right.
Correct. So I think this is where we go in terms of isolated teratozoospermia or isolated morphology abnormalities. I think we come to the end of this Father's Day special podcast. We've had an excellent discussion with Ranjit sir regarding andrology training, what he has achieved in his life, what's next for andrology. We did understand that the fertility rates are decreasing as years are passing, but we also need to understand that fertility treatments are improving, and with better and better male fertility care and better male fertility treatment medicines, I think we should be able to attain parenthood, fatherhood in couples who want biological kids for themselves. Surgical treatment has evolved over a period of 10 to 15 years. And Ranjit sir, he has himself told that it has evolved completely over these 2 decades. And I'm sure it will keep evolving with new research going on. We should be able to find out what are the causes of male infertility and what are the possible treatments that we can give to improve the fertility. Though the fertility rates have declined over a couple of decades, I think fertility treatments have also improved in the same rate over the last 2 decades. Ranjit sir, thank you so much for joining us. Thank you so much for your inputs. You can give your last thoughts, and thank you so much, Mere Organics, for this wonderful parenthood, fatherhood podcast on Father's Day, on the eve of not the eve of the Father's Day, but yes, something for the Father's Day.
No, thanks, Tejas, for doing this, and thanks to Meyer for organizing this wonderful webinar. I think the one thing that you sort of mentioned that we, as physicians who help men and their partners to achieve pregnancy, is we give them hope. We give them hope in terms of medical treatments, in terms of, we talked about antioxidants, in terms of surgical treatments, in terms of hormonal treatments. I think 20 years ago, this was not even a big talked about topic. People hid male fertility. They didn't want to even check a sperm analysis. This was a big taboo. I think now, at least in the last 2 decades, people are talking about it. The prevalence is increasing. But the nice thing to offer on this Father's Day is to offer hope. Hope for treatment, hope for reversing the underlying problem, and hope for a biological parenthood. So with that, we'd like to thank you all for attending this webinar, and thank you for hosting us. Thank you.
Thank you so much. Thank you so much.
Oh, you finished. Wait, hold on.
Done.
You just stood up.